Today, I'm going to describe antibiotic and opioid prescribing and overprescribing by dentists and adverse events associated with dental prescribing. And we'll also provide some preliminary evidence on effective stewardship interventions that have been targeted to dentists. So I will describe multiple different data sets today. The first will be Medicare Part D prescription data, which is primarily persons getting prescriptions reimbursed or covered by Medicare. And this is primarily a population over the age of 65 years. I will also describe population level prescription data, of which is comprised of 92% of all prescriptions dispensed from outpatient pharmacies. But I do want to note that this does not include VA or Department of Defense data. I'll describe some claims data from MarketScan, which the population in this data set are persons with commercial or Medicare insurance and who also have commercial dental insurance. And then I'll share some data with you from the VA, which is the largest oral health care provider in the United States. And VA dentists care for approximately 500,000 veterans annually who receive 1.9 million dental visits. So my focus today is prescribing by dentists because I have two large grants focused on that exact topic. And also because that is what I was asked to speak about today. But I do want to note that dentists are not the cause of the opioid epidemic or bacterial resistance. They are one prescriber group that prescribes these medications. And during our discussion today, I want for you to keep in mind, especially for those of you who are not dentists in the audience, that the majority of dental practice is treating pain and infection, preventing an infection, or causing pain to treat or prevent an infection. However, unfortunately, dentists have largely been left out of the public health conversation on the opioid epidemic as well as mounting bacterial resistance. But I want everybody to understand up front that dentists are part of the solution because dentists are the top specialty prescriber of both antibiotics and opioids in the US and are generally considered to be high prescribers of these medications. And of course, these medications have high public health implications. There are also national action plans that recommend curtailing prescribing of these medications. There's the National Action Plan for Combating Antibiotic-Resistant Bacteria and the National Action Plan for Adverse Drug Event Prevention, which includes opioids. However, data is scarce on how and why dentists prescribe antibiotics and opioids, and few interventions have specifically focused on improving prescribing by dentists. In addition, antibiotics and opioids are the majority of medications prescribed by dentists. With Medicare Part D data, we identified that almost 60% of all medications prescribed to Medicare Part D beneficiaries were antibiotics, and approximately 20% were for opioids. Now, I know some of you are thinking, well, Medicare Part D is a very specific population. And while I agree with you, I want to say that even if we look at population level prescription data of all payer groups and those who are uninsured, as well as the VA, we see very similar trends. About 55 to 60% of all medications prescribed by dentists are for antibiotics, and about 15 to 20% of medications prescribed by dentists are for opioids. I also want to note that this is a hot topic in the geriatric literature. This paper was just published in the Journal of the American Geriatric Society on the preventions of oral infection in older adults. And for those of you who are not familiar with this topic, I think this is a really nice summary on what happens as we get older in our oral cavity. So what changes occur in the oral cavity, the importance of access to oral health care in older adults, and why antibiotic and analgesics are indicated and risks associated with use. So if you're not familiar with this paper, the reference is here at the bottom of the slide. So first, let's discuss opioids prescribed by dentists. So in the US, dentists prescribe 1 out of every 8 short-acting opioids. And the majority of opioids prescribed by dentists are hydrocodone-containing products. However, 10% of opioids are for high potency or long-acting agents. An example of a high potency agent is oxycodone, and an example of a long-acting opioid is OxyContin. We also know that opioid use is very common among older adults. Older adults have a high prevalence of chronic pain, or they may have contraindications to NSAIDs or non-steroidal anti-inflammatory drugs. We compared opioids prescribed by VA dentists and medical clinicians. Medical clinicians are defined as physicians, nurse practitioners, and physician's assistants. And of course, we can only do this analysis in an integrated healthcare system, which of course the VA is an integrated healthcare system. We found that medical clinicians actually had a higher visit-based opioid prescribing rate. But over this study period, which I believe was from 2015 through 2018, we saw that both groups had a significant decrease in opioid prescribing. But the decrease was greater for medical clinicians. And this was likely due to multiple opioid safety initiatives that have been implemented across VA since 2006 that have primarily targeted medical clinicians, specifically physicians. However, even though nothing has specifically been targeted to dentists, we still saw a decrease in opioid prescribing. Interestingly, we found that VA facilities with dentists with the highest opioid prescribing rates, they were not at the same facility as high prescribing medical clinicians. And why is this important? Because operations frequently targets interventions to the highest prescribing facilities, and therefore dentists may not be benefiting from these interventions. Unfortunately, there are no US guidelines for the treatment of oral pain. So we have adopted the Centers for Disease Control and Prevention guidelines, which recommend limiting opioids to 3 days for most acute pain. And this is also supported by recommendations in the dental literature, which recommend hydrocodone 10 milligrams every 6 hours for 2 or 3 days, or a maximum of 12 tablets. Now, most of you are probably familiar with the term of MME, or morphine milligram equivalents, and this is a measurement of potency. So 12 tablets of hydrocodone is equivalent to 120 morphine milligram equivalents. So in general, it's not recommended to exceed 120 MMEs per prescription. I do want to note that the VA did release guidelines on the treatment of oral pain last year. And I also know that the American Dental Association has a guideline panel. They're forming a guideline panel as we speak. So all good news. So as I alluded to on the last slide, we applied the definitions or the CDC guidelines of opioid overprescribing. So we looked at prescriptions that exceeded 3 days supply or 120 morphine milligram equivalents, or MMEs. This was in a cohort with patients with commercial dental insurance. We found that half of opioids exceeded 3 days supply, and 30% exceeded 120 MMEs. And opioids that exceeded the recommended MMEs actually increased over the study period. Patients that were located in the southern US, men and younger adults, were most likely to be overprescribed opioids. And this is concerning because these patients are at the highest risk of an opioid-related overdose. However, we did see that there was a decreased odds of opioid overprescribing in those persons over the age of 65 years. We also found that overprescribing would decrease by 20% if oxycodone was substituted with a lower potency opioid. So some of you may be familiar with the literature that has compared the oral health metrics between various countries. And some of those comparisons have been done between the US and England. So these two countries have similar oral health as well as use of the dentist. We compared opioid prescribing by dentists in the US and England, and both data sets were population level data. We found that US dentists prescribed opioids 37 times as frequently as English dentists. And this is likely a similar trend as if we also did the analysis with medical clinicians. US dentists also prescribed a much wider range of opioids, where English dentists only prescribed dihydrocodeine, which is available in the US but is rarely prescribed. And dihydrocodeine is a codeine derivative. And opioids prescribed by dentists can have safety implications. And before I discuss that, I want to provide a brief overview of the Beers criteria. The Beers criteria is a list of drugs that are potentially inappropriate to use in older adults. We call these medications potentially inappropriate medications, or PIMS. And this list of medications is updated every 3 years by the American Geriatric Society. And we need the Beers criteria because polypharmacy, or the use of 5 or more drugs, is prevalent in older adults. National estimates state that about 40% of older adults take 5 to 9 medications, and 20% of adults over the age of 65 take 10 or more medications. We also know this is important because polypharmacy is associated with inappropriate prescribing and adverse drug events. The American Geriatric Society Beers criteria includes a list of certain drug classes. So the Beers criteria is not comprehensive. It's very specific to medications that are at a higher risk in older adults. So these medications are drugs that should be used with caution in older adults, those that should be avoided, notable drug-drug interactions, again, that are more significant or more likely to occur in older adults, drugs that should be renally adjusted in older adults, and drugs where there is high evidence of harm in older adults. And this list is a guide. It's meant to be combined with clinical judgment. It states that some medications still need to be used in older adults, but these patients should be more highly monitored, and the list is not meant to be punitive. So what I did is I went through the Beers criteria and I pulled out a handful that are more relevant for dentistry. Now, I would like to say this is not meant to be all-inclusive, so please review the full list at your leisure. It is available on the American Geriatric Society website, as well as I included the full citation at the bottom of these sets of slides. So again, these are medications that dentists tend to prescribe. And in older adults, it's recommended to avoid benzodiazepines because of increased cognitive impairment and the increased risk of falls. NSAIDs, it's recommended to avoid chronic use in older persons because of an increased risk of peptic ulcer disease and GI bleeding. It's also recommended to avoid muscle relaxants because of the increased risk of sedation and falls. And tramadol is recommended to be used with caution because of hyponatremia in older adults. So I stated that the Beers criteria also has a pretty lengthy list of disease-drug interactions as well as drug-drug interactions. So those that I pulled out to share with you today are to avoid NSAIDs in older persons with a history of GI ulcers and chronic kidney disease, and to avoid opioids and benzodiazepines in older persons that have a history of falls or fractures, dementia, or cognitive impairment. Now, there's 3 drug-drug interactions I wanted to talk about today. This is combining opioids with benzodiazepines, opioids with gabapentin or pregabalin. I'll just refer to those as gabapentin for the rest of the presentation, and opioids combined with 2 central nervous system active drugs. So why do we talk about central nervous system drugs? In general, it's recommended to avoid 3 central nervous system drugs in older persons. And of course, an opioid is a CNS active drug, as well as antidepressants, antipsychotics, antiepileptics, and those Z drugs, or zolpidem. And we looked at these 3 combinations of medications in older persons that received an opioid on the same date as a dental visit. These combination of medications are significant because combining opioids and benzodiazepines have an increased risk of opioid-related overdose in general in all patients, but also an increased risk of cognitive impairment and falls in older adults. Opioids and gabapentin have an increased risk of sedation, And opioids and two CNS active drugs increase the risk of falls, sedation, and again, using three CNS active drugs is generally contraindicated in older persons. We found that 1 in 10 older adults received a potentially inappropriate medication combined with an opioid prescribed by a dentist. And this resulted in a 23% increase in ER visits and hospitalization. And increasing MMEs, or increasing potency of the opioid, was associated with an increase in ED visits and hospitalizations. Interestingly, 22% of the benzodiazepine prescriptions, gabapentin or pregabalin, or the CNS active drugs were dispensed just the day before the dental visit. So why is this happening? Well, of course, elderly have contraindications to non-opioid analgesics, as well as most of the information that dentists have on patient comorbidities and their concomitant medications is self-reported by the patient. Because few dentists have access to an fully integrated healthcare electronic health record where they can see the electronic medical record. But pharmacists, while pharmacists do not have access to the electronic healthcare record, pharmacists typically have access to the complete medication profile of patients. And therefore, we recommend that pharmacists and dentists collaborate to prevent this hazardous co-prescribing. Now, there have been a few implementation strategies to improve opioid prescribing by dentists. There was a dental clinic in Pittsburgh that embedded a pharmacist in the clinic and found a subsequent improvement in opioid prescribing. A state in the Northeast was an early adopter of mandating query of the state prescription drug monitoring program. And the first provider group that they mandated a query were dentists, and found a significant decrease in opioids prescribed by dentists in that state. We implemented a patient-focused educational intervention prior to patients undergoing tooth extractions, and found that patients who were randomized to the educational intervention took fewer opioid tablets. And at a policy level, the Food and Drug Administration upscheduled hydrocodone in 2014, changing hydrocodone from a C3 to a C2, which placed additional prescribing restriction on hydrocodone prescriptions. So the FDA upscheduled hydrocodone in late 2014, which is shown in the dotted line in the middle of each of these graphs by the vertical bar, the vertical dotted line. After the upscheduling, we saw a rapid decrease in hydrocodone prescriptions, and we saw an increase in codeine-containing products. However, upscheduling also had unintended consequences, where oxycodone increased and tramadol increased, which is an agent that is generally thought to be ineffective for oral pain. Now, I want to note here that the y-axis is number of prescriptions, but the results are the same with population-based rates as well as provider-based rates. So now we'll switch gears and we'll discuss antibiotics prescribed by dentists, which again is about 65% of all medications prescribed by dentists. So just to make sure we're on the same page, I wanted to review that the majority of human antibiotic use in the US is in outpatients, so dispensed from outpatient community pharmacies. We are seeing some success in outpatient efforts to prescribe antibiotics judiciously, where antibiotic prescribing decreased by 5% over 6 years. However, most of this decrease was due to decreases in antibiotics prescribed by physicians, particularly pediatricians, to children. And antibiotic prescribing by non-physician clinicians has increased significantly. Using private sector data, so population level data for the US, we found that the antibiotics prescribed by dentists increased, especially for clindamycin. We also found that the antibiotic days supply also increased. And this is concerning because historically, clindamycin has been associated with the highest risk of C. difficile infection. In fact, dentists are the top specialty prescriber of antibiotics in the US, prescribing 1 out of every 10 antibiotics, right after family practitioners, nurse practitioners, and internists. So similar to what I described with opioids, we also compared VA medical clinicians and dental providers for antibiotic prescribing, and found that dentists had a higher visit-based antibiotic prescribing rate when compared to medical clinicians. And similar to what I mentioned with opioids, VA facilities with the highest prescribing dentists were located at different facilities than the highest prescribing medical clinician. We also see this trend using population-based data for dentists versus nationally. In this slide, the map on the left are antibiotics prescribed by dentists. And the map on the right is a map from the CDC website, which is all antibiotic prescribing by all prescribers. So in these maps, the darker red states indicate higher prescribing rates. And in the map on the left with dentist prescriptions, the highest rates are in the Western US, and the lowest rates are actually in the Southern US. However, for all prescribers, the highest antibiotic prescribing rates are in the South, and the lowest is actually in the West. So why does this matter? Because public health focuses some stewardship efforts based on areas with higher antibiotic prescribing. Thus, these efforts, again, are not reaching areas with the highest dental antibiotic prescribing rates. It is important to note, however, that there is inherent differences in how dentists and medical clinicians prescribe antibiotics. So dentists primarily prescribe agents in the penicillin class. However, medical clinicians primarily prescribe macrolides to adults and penicillins to children. Dentists prescribe very few broad-spectrum agents. In our data, we see about 5% of all antibiotics prescribed by dentists are broad-spectrum, versus for medical clinicians, about half of antibiotics prescribed are for broad-spectrum agents. However, dentists are the primary prescriber of clindamycin in the US, and dentists prescribe way more antibiotics for preventative reasons and not for the treatment of infection. So an example of an indication where a dentist prescribes an antibiotic for preventative reason is to prevent infective endocarditis in patients with certain cardiac conditions. In our data, we estimate that 85% of all antibiotics prescribed by dentists are to prevent an infection. However, even though dentists primarily prescribe antibiotics for prophylaxis, which is typically one dose prior to the dental visit, the antibiotic days supply is similar as medical clinicians. And then finally, dentists are also uniquely pressured to prescribe antibiotics, not only by patients, but also by medical clinicians. And dentists perceive significant pressure to prescribe an antibiotic based on the influence of a medical provider. Dentists primarily prescribe two antibiotics. Amoxicillin, overwhelmingly about 60 to 70% of all antibiotics prescribed by dentists, followed by clindamycin. And we see a median day supply of 7 days. And again, this day supply is similar as medical clinicians. So there are guidelines that recommend administration of an antibiotic prior to a dental visit. And this recommendation is 1 dose of an antibiotic in patients meeting 2 criteria. First, that the patient have a dental procedure with gingival manipulation or perforation of the oral mucosa, which I'll refer to as gingival manipulation. And the second criteria is patients having a cardiac condition at the highest risk of an adverse outcome if the patient does develop infective endocarditis. These indications include patients with prosthetic cardiac valves, patients with a past history of infective endocarditis, patients who have a cardiac transplant with valvulopathy, and certain congenital heart defect. But antibiotics are no longer recommended prior to dental visits in patients with prosthetic joints. We assessed antibiotics prescribed by dentists for preventative reasons in that population with commercial dental insurance. We found that 91% of visits had that gingival manipulation criteria, but only 20% of patients had one of the high-risk cardiac conditions. Therefore, 80% of antibiotics prescribed prior to dental visit were unnecessary or prescribed outside of clinical treatment guidelines. Patients who were in the Western US lived in urban areas, and patients with prosthetic joints were predictors for antibiotic overprescribing. However, we did see that antibiotic overprescribing did decrease over time. Now, dentists do occasionally prescribe antibiotics prior to a tooth extraction or prior to a dental implant. And there's some evidence from 2 different Cochrane meta-analyses to support 1 dose of an antibiotic prior to an extraction or an implant. However, the meta-analyses also note that the benefit of administering an antibiotic did not always outweigh the risk of an antibiotic-associated adverse event. We found about 80% of veterans who had a dental visit with a tooth extraction or a dental implant received antibiotic prophylaxis. However, 70% received post-procedure antibiotics for 7 days when only 1 dose pre-procedure was indicated based on these Cochrane meta-analyses. So antibiotic duration could be a key area to target to improve antibiotic prescribing by dentists. We also looked at the patients who received unnecessary antibiotic prophylaxis. And these patients received antibiotics for a very short duration, less than 3 days, so only a day or 2. In summary, we found that even though these antibiotics were prescribed for a short duration, they were not without risk. We found that 1.4% of patients had a serious adverse event within 2 weeks of the dental visit, either an antibiotic allergy, an ED visit, or C. difficile. And we know this is a very conservative estimate of adverse events because, first of all, the patient had to be sick enough in order to seek medical care. And we use claims data for this analysis. So we had to have a diagnostic code associated with the adverse event. And diagnostic coding for allergies and C. difficile is generally poor, and that's been demonstrated by other investigators. One other alarming thing we have found from this project, we found that clindamycin was more likely to be unnecessarily prescribed and more likely to be associated with a serious adverse drug event. I mentioned in our studies that for C. diff and allergies, that diagnostic coding is poor. However, public health, especially your state departments of public health, have prospectively collected data on CDI and estimated that 8 to 30% of community-associated CDI are associated with an antibiotic prescribed by a dentist. A UK study found that single doses of clindamycin prescribed for prophylaxis were associated with adverse events. And the most common adverse event noted was C. difficile. However, most of these adverse events are treated in medical settings. So dentists are generally not aware when their patient experiences adverse event. Similar to the analysis I described with opioids, we've also compared antibiotics prescribed by dentists in Australia, England, British Columbia, Canada, and the US. US dentists had twice the population-based antibiotic prescribing rate than Australian dentists. And these 4 countries have shown to have similar oral health. Now, the most frequent agent prescribed by dentists in all 4 countries were penicillin in the penicillin class, but the second most frequent agent was metronidazole in Australia and England, and clindamycin in Canada and the US. So why do we see such significant differences between these 4 countries? Well, of course, because guidelines differ. In Australia and England, there's never been a recommendation for antibiotics to be prescribed in patients with prosthetic joint. And of course, there were some guidelines in the past that recommended certain patients with prosthetic joints receive an antibiotic, but that is no longer the current recommendation. We also know that there's differences in practice for antibiotic administration prior to extractions and implants, where that's not routine in England and Australia. We also know that in the US and Canada, there's a broader definition of what comprises this high-risk cardiac conditions in patients that are indicated to receive infective endocarditis prophylaxis. So now we have some data in hand, and we know that strategies are needed to improve antibiotic prescribing. And while I'm focusing today on dentistry, I do want to note that a bigger push to fully implement antibiotic stewardship in the outpatient healthcare setting is sorely needed. So what can we do to decrease antibiotic-related adverse events while improving antibiotic prescribing by dentists? We can implement antibiotic stewardship, which is a set of strategies or interventions to improve antibiotic prescribing by clinicians and antibiotic use by patients. So I know some of you probably practice in acute care, and similar to acute care, the CDC has provided core elements to implement antibiotic stewardship in outpatient healthcare settings. And one of the settings recommended by the CDC to implement stewardship is dental practices. So we applied these 4 core elements to develop and implement the first interprofessional dental antibiotic stewardship program. And this was done at my previous institution, the University of Illinois at Chicago. So briefly, to describe these core elements, the first is a commitment to improve antibiotic prescribing by clinicians and patient safety. The second core element is to provide educational resources and needed expertise. The third core element is action for policy and practice, which is implementing an intervention to improve antibiotic prescribing. And the fourth core element is tracking and reporting, monitoring antibiotic prescribing, and offering feedback to clinicians. We had a very strong leadership commitment to optimize antibiotic prescribing from the colleges of pharmacy, the colleges of dentistry, and the co-director of the antimicrobial stewardship program at the health system. A single stewardship leader was also identified, which was the director of the urgent care dental clinic. And the implementation and maintenance of the dental antimicrobial stewardship program was included in the strategic plan for the dental clinics. Dentists were provided expertise from an endodontist, an oral surgeon, and an infectious disease pharmacist and physician that co-led the antimicrobial stewardship program. We also provided continuing education sessions on guidelines relevant to dentistry as well as antibiotic stewardship. And these CE sessions were provided live as well as on demand. We also sent out a Monday Minute, and this was an email sent out every Monday morning. And these emails had key targeted messages that were meant to be read in under a minute. The messages focused on, again, guidelines that are relevant to dentistry, national antibiotic prescribing trends, key topic areas on resistance and C. difficile, and general antibiotic stewardship messaging. And then we also used behavioral nudges to influence prescribing. And we hung educational posters in staff areas as well as chair side or next to the dental chair. These posters were the checklist for antibiotic prescribing in dentistry, 7 ways dentists can act against antibiotic resistance, and a patient-focused poster, which is shown here in this slide, antibiotic do's and don'ts at the dentist. And all 3 of these posters are available for free from the CDC website. The third core element, action for policy and practice, we developed and implemented local guidelines and a clinical decision support tool on the treatment of oral infections. And this is prior to the ADA releasing their guidelines. The guidelines were released last year. We simply printed this out on a piece of paper and hung it next to the dental chair within the dentist view. This subsequently has evolved to pathways for prescribing antibiotics for prophylaxis, and recently a standardized process has been implemented to engage primary medical clinicians on prophylaxis decisions. And we're currently planning for future strategies. For tracking and reporting antibiotic prescribing, we conducted a review of systemic antibiotics at baseline. And this informed our initial focus of the urgent care dental clinic and the treatment of oral infections. We shared the baseline report as a peer comparison report during clinic staff meetings. And we also shared the results of our initial program evaluation during a clinic staff meeting. So overall, after implementation, we found that implementation of the dental antibiotic stewardship program resulted in a 70% decrease in antibiotic prescribing rate. We also received a lot of anecdotal feedback that the dentists had an improved understanding of the importance of every antibiotic that they prescribed. Now, I do want to note that we did this in academia, and there are likely many resources available in an academic dental practice that are not available in a private dental practice. And I agree with you, and I'm hoping to expand this work to private dental clinics. And if you're interested, please feel free to email me. Now, we're not the only ones that are doing this type of work. At The Ohio State University, they sponsored a town hall with dentists. These were private practice dentists, as well as academic dentists and orthopedic surgeons. In this town hall, they had many lectures on antibiotic on guidelines and stewardship, and then they had roundtable discussions on specific cases. And overall, the participants came to a mutual understanding of the guidelines for prevention for antibiotic prescribing in patients with prosthetic joints. But they also identified a couple of gray areas where additional research was needed. There are also antibiotic stewardship toolkits that are available for free online. One is through the Illinois Department of Public Health, which is shown here in this slide. And there's also a very nice toolkit available from the state of Massachusetts. Besides posters available from the CDC, which we used in our program, there are also posters available from the states of Michigan and Minnesota that are customized to dental practice. And I also want to note that there's statements from professional organizations supporting the implementation of antibiotic stewardship in dentistry. This includes the American Dental Association, the FDI World Dental Federation, and the Association of State and Territorial Dental Directors. And there's also free education on antibiotic stewardship. There's an antibiotic stewardship training module available from the CDC, and one specific part of that training session is focused on dentists. And the FDI and the British Society of Antimicrobial Chemotherapy have a MOOC that's available online as we speak, which is totally customized to the implementation of antibiotic stewardship in dentistry, and is meant for a worldwide audience. It's not specific to UK dentists. But I want to note that there's a significant area of opportunity for antibiotic and opioid stewardship in dentistry. But there are unique challenges in the dental setting. This includes limited access to data, especially to the electronic medical record. And in very few settings is the EMR linked to the electronic dental record. For some areas of dental practice, there is still limited evidence. There's still a limited evidence base as well as resources customized to dentists. But more and more data is becoming available to inform our efforts. But I do want to note, especially for the antimicrobial stewards that are listening today, that it's important to keep in mind that antibiotic prophylaxis decisions may be driven by surgery colleagues. But as with any new QI strategy that you're implementing, the first step is just initiating the conversation and just starting to talk to people who have similar interest in improving antibiotic and or opioid prescribing. And in our work, we had a really nice conversation about the CDC core elements, which were new at the time, and showing that dentists and dental practices were included as part of the targeted audience. And that alone went a long way just on starting to implement some strategies to improve antibiotic prescribing.